Early intervention is very, very important. We know that many of these injuries injuries to the central nervous system that end up resulting in neurological tone begin third day. So the patient is still in the ICU and they may be very ill, but many brain and spinal cord injuries that do go on to develop neurological tone, you will start seeing that drawing in and that tension the third day. So it's very important that we recognize it in the ICU, that we address it appropriately, not with rigid orthopedic splints, but with flex technology splints. This gives us the opportunity to perhaps prevent, if not all the deformity, at least most of the deformity. So we see patients going into the rehabs with no deformity and going home, hopefully to their home with no deformity or much less deformity than they would have, maybe even walking rather than leaving in a wheelchair. That is where we need to go. Today we typically address patients once they start the deformity. That's just as early as possible is when we want to address it. And it doesn't matter how far down the road they are. They can be years down the road and we still address them, but we just follow the process. And we'll talk about the process in a little bit. A very, very talented therapist named Michelle Miller is a pediatric occupational therapist. She's from Louisville, Kentucky, and she owns her own pediatric clinic in Mississippi. She called me several years ago and said, "Karen, I have to tell you, I never expect to have another child go through my clinic that develops scoliosis." Now this is profound, and I was relating this to a chief of brain injury at a very large, prestigious rehab facility not long ago. And he looked at me and he said, "Now Karen, do you really believe that?" And I said, "Well, in my mind, it's like this. You have the spine, so you have all these bones stacked one on top of each other. And we know when you have brain or spinal cord injury, it's very, very common to develop neurological tone. So you have the inappropriate contracting of the muscles. Now we know that can very easily pull those bones of the spine offline. And if we allow that to go on long enough, then we have shortening of the muscle tissue, and then we can have a real mess to start trying to bring back. We also know that if we continually relax that muscle firing, then in my brain, we leave the spine intact. And this wonderful physician looked at me and smiled. He said, "You know, I never thought of it like that." In dealing with neurological patients, we just need to use our imagination. Restorative Medical has a slogan that we are where patient care is not compromised by our lack of imagination. Now we don't, go clear out of the world, but we do try to look at it with a clean slate and we say, what makes sense? What is just good common sense? In Kentucky we talk about horse sense, and it's just common sense. And what we do is very, very simple. It's just, again, we do one thing and then we step back and watch how the body reacts. And then we do another and step back and watch how the body relaxes. We must work through tone to reach that muscle inhibition. The same therapist, Michelle Miller, told me about a little girl that had come into their clinic. She has spina bifida and severe upper body tone, so she was contracting like this. They had gone through 5 different hand splints trying to help her little hand not be so tight. She put the Restorative Medical little hyper hands on her, which have the flex technology. In 20 minutes, her hand totally relaxed. They took the splint off and the hand remained relaxed. Now, this is very important because with an orthopedic splint, the body is addressed while the splint is on. The splint is doing something. With restorative splints, with flex technology, the splint is just the tool. The body is the one that is doing something. So when we relax that neurological tone, theoretically you can take the splint off and the hand, whichever part of the body you just addressed, will stay relaxed until something else kicks that tone in. This is a 22-year-old patient with cerebral palsy. His diagnosis was cerebral palsy. And if you'll look, he had very, very, very severe contractures. His dad and stepmom had kept him at home and taken care of him until they became older and could no longer take care of him, and they did a really good job. His skin was just in wonderful condition. But before I took the picture, I took his hospital gown and put it under the rib cage so you can see. The younger these people are, these patients are, when they start to develop tone, the more they tend to twist and turn. Well, if you think about it, your rib cage is, all these bones are attached to the spine. So as the spine goes offline, it's definitely going to have an effect on the rib cage too. And you see his right ribs come out in a point, and this is not unusual at all with these patients. His hands, you'll see, are in like a bullfrog position. He had quite a bit of tone in the wrist. His left leg, you see, come out, knee in about a 90-degree flexion. Then the right knee is underneath his body, goes up perpendicular to the trunk of his body, and the foot is down. The therapist where he was moved to a nursing home had never seen a patient with quite this bad a contracture. So I went in to do a consultation, and you can see the results. Now, all the pictures you will see in these case studies are taken within about 15, 20, 30 minutes of their initial fitting. So they're going to demonstrate tone. Again, the process to re-lengthen shorten tissues, we said that 6 weeks of prolonged low-load passive stretch to even realign the proteins in the muscle, the actin and myosin. So we don't want to think about re-lengthening tissue until we have a good handle on the tone. So when you fit a patient with a device for neurological tone, you want to just set it to work through tone. You're not going to be real aggressive. You want it to very easily allow that patient's joints to reach relaxation repeatedly. Then after about 6 weeks, 2 months, then you can think about re-lengthening the shortened tissue. But you can see what an amazing effect it had on this young man's body just by allowing him to relax. These are pictures of a lady that they were sent to me by the fitter who did her. She was in another state, and her diagnosis was actually osteoarthritis, but she looks like she might have had some rheumatoid going on just because of the ulnar drift, and this would be ulnar drift from the MCP joints, and the fingers very commonly go like this with rheumatoid arthritis. But the fitter thought that she was going to be taking care of a patient that was in bed, or at least in a chair. It was at the patient's home, and it was a northern state. It was during the winter, and there was snow on the ground. So when she pulled up to the house, she saw this little lady out in the front yard shoveling off the snow off her driveway, and this was the patient. And when the fitter got out of her car and remarked about it, and the lady said, "Yes, this is why I need you to fix my hand, because I want to continue to be able to scoop my own driveway off and my sidewalk and be independent and remain here at home." It's just very important that we keep people's bodies in good alignment so they can stay home and don't have to move to a nursing home for this care. Nursing homes are wonderful, and they serve such a vital purpose. But we have more people than the nursing homes can absorb these days, so we have no choice but to keep people healthier and keep them at home. But this splint was actually designed by the fitter with the patient's help. Now, this lady was in her 80s. She knew exactly what she wanted. And these are sewn in ulnar drift finger separators, which would bring the fingers back in this direction. Today, this was a custom-made hand splint. Today, we do those prefabbed where you can put them on any of our hand splints and they just Velcro on. Gives you a lot more flexibility. This is Miss Dorothy. Miss Dorothy's another lady who was a widow and wanted to stay at home. You can see she had some pretty profound osteoarthritic changes in her joints and had been accumulating for some years, but she had TIAs, she had mini strokes, and within 2 weeks her index fingers flipped back in her palms. These conditions are fascinating because you can trace that back. If you know what spinal nerve's coming off what part of your spine, you can trace where the damage has come down. But they were very, very stiff and very painful. So now these are really old pictures, but this was the beginning of us starting to do the customized finger separators to address specific issues. Once you very, very gradually stretch the finger back out, then you want to maintain it there, allow it to work through the tone and relax, but keep it in that good normal body alignment to prevent deformity.